Well, good afternoon. First of all, I'd just like to get a show of hands. How many people in this group either have sleep issues or know people that do have sleep issues? Oh, wow. Okay. So you're in the right place, and hopefully I'll get to some of your questions at the end of this. So today I'm going to be covering three basic topics. I'm going to cover the need for sleep, and then I'm going to focus on two sleep disorders. These two sleep disorders happen to be the most common sleep disorders out of the almost 90 different sleep disorders. So in regards to the need for sleep, we look at the prevalence of sleepiness, and it's estimated that over a third of the population suffers from sleep loss, and this includes 1/3 of young adults secondary to chronic partial sleep deprivation. It also includes about 7% of adults secondary to sleep disorders. And lastly, there's about 2% of adults that have sleep issues secondary to shift work. Now, if you go into further and look at daytime sleepiness, 1/3 of adults sleep less than 6.5 hours during the work week, and approximately 1/3 of normal adults fall asleep in less than 5 minutes. How we know this is we actually have a test called the multiple sleep latency test in our lab, and this test is found in all other labs throughout the world. What it is there's 5 scheduled naps. So it starts at 9 o'clock in the morning, and it goes 9, 11, 1, 3, and 5. Each nap lasts about 20 minutes, and we see how long it takes a person to fall asleep. And then we average how long it takes them to fall asleep. If they fall asleep in less than 8 minutes, they're considered to have significant daytime sleepiness. So you can see here that approximately 1/3 of normal adults fall asleep in less than 5 minutes during the daytime, and that's considered pathologic sleepiness. Now, when you look at it further, when total sleep time in normal young adults are reduced just by 1 to 1.5 hours, just for one night, you get decreases up to 1/3 in objective alertness the next day. So just one night of partial sleep deprivation can have profound effects the next day. So now I'm going to talk a little bit about sleep stages. So as most of you probably know, there's 2 different states of sleep. There's non-REM sleep and REM sleep. REM sleep stands for rapid eye movement sleep. And rapid eye movement sleep, about 90% of the dreams occur during that state of sleep. And also, it's a time of cardiorespiratory instability. What that means is that that's a time when your heart rate becomes irregular, and also your breathing becomes shallow and irregular. And that's also the time when most of obstructive sleep apnea occurs. Now, non-REM sleep, you can see, is divided into 3 stages. It used to be called 1, 2, 3, and 4, but they lumped 3 and 4 within stage N3. So as you go down that list from N1, N2, and N3, that reflects the deeper stages of sleep. So N3 is actually the deepest stage of sleep, and that's the hardest to waken the person up from. Now, if you look at how sleep changes over the lifespan, it actually doesn't look too great, because as you get older, what happens is your sleep amounts tend to decrease, not only REM sleep and non-REM sleep. And you can see when you're first born that you can have 16 to 18 hours of sleep, and of that, about 50% is REM sleep. That's why some people believe that REM sleep is responsible for brain maturation and growth and development. And as you can see, it slowly decreases over time. And if we look at it a different way, you can see this. And what it shows that children, they're really good sleepers. So their sleep tends to, the REM sleep tends to increase as the night goes on, and the deepest time of their sleep is in the first half of the night. So this portion is when they get the most deep sleep. Young adults are also considered pretty efficient sleepers, meaning that of the time that they're in bed, most of the time they're asleep. And you can see they have very few awakenings. And there's also the logical progression of the REM sleep. The REM sleep periods get longer and more intense as the night wears on. Now, as you get older, what happens is that your sleep becomes more fragmented. You start decreasing the amount of non-REM and REM sleep. And this sleep pattern very much approximates a person that has insomnia, because they have difficulty falling asleep as well as difficulty staying asleep. And consequently, what happens is during the daytime, they tend to be more sleepy. And also, there's a nucleus in the brain called the suprachiasmatic nucleus that's responsible for the sleep-wake cycles. And as the person ages, so do these cells in that nucleus. And because of that, the circadian clock, meaning the sleep-wake clock, tends to shift. And because of that, you tend to want to sleep earlier and get up earlier. Now, two large groups met to decide on what is a total sleep requirement. And they met just last year. One was the American Academy of Sleep Medicine. The other was the National Sleep Foundation. And for the Academy of Sleep Medicine, what happened is they basically brought in a group of sleep experts in a large room. And basically what happened is we reviewed all the relevant articles regarding sleep need and how many hours a person should sleep. And basically we came up to the conclusion that a person, an adult, should sleep 7 or more hours per night on a regular basis to promote optimal health. Now you can see some of the repercussions of sleeping less than 7 hours on a regular basis. It increases your chance of having weight gain, obesity, diabetes, high blood pressure, heart disease, stroke, depression, increased risk of death as well. Now, if you sleep more than 9 hours on a regular basis, it may be appropriate for some young adults, individuals recovering from sleep debt, and individuals with illnesses. Now, people concerned that they are sleeping too little or too much should always consult their primary care physician or sleep specialist. And what's kind of interesting is, if you look at some of the data more closely, what you find out is that there's a U-shaped survival curve. So people that sleep less than 4 hours and greater than 10 hours on a regular basis, they have a higher risk for mortality. And you might think this might be a fluke, but it's actually been replicated in about 4 large epidemiologic studies. And they tried to control for as many factors as possible, such as things like age, smoking, eating habits, alcohol use. But I think it's impossible to control for everything. That's why, at least from the American Academy of Sleep Medicine, we didn't really set an upper bound of 10 hours. So what are the things that sort of drive sleep? Well, melatonin is something that does influence the timing of sleep. And you can see melatonin that's in the body tends to increase during the night and also in the early morning hours. And that very much coincides with core body temperature. So when your core body temperature tends to decrease and your melatonin rises in your body, that's the time that you tend to be very sleepy. And this subjective scale looked at where 100 is very alert and 0 is not alert. And you can see that when you're most sleepy coincides with the melatonin peak as well as the decrease in body temperature. Now, one thing that we look at in the clinic is your tendency to be sleepy during the daytime. And you can find the scale on the internet, and it's called Epworth Sleepiness Scale because Murray Johns, who developed the scale, actually is from Epworth, Australia. And basically, you look at these 8 sort of real-life situations, and you put 0, 1, 2, or 3. 0 is no chance of dozing. 1 is slight chance of dozing. 2 is moderate chance of dozing. 3 is high chance of dozing. So for each one of these real-life situations, you put 0, 1, 2, 3, and you add them up. Now, the cutoff is 10. So if you add up all those points and you're greater than or equal to 10 points, then it might not be a bad idea to talk to your primary care physician or sleep specialist. The only caveat for that is that if there are other things that sort of influence the daytime sleepiness, like, for instance, if you have a very big work and family life and you find out voluntarily that you're only sleeping 4 to 6 hours during the night, well, obviously that would cause daytime sleepiness. So this assumes that you're trying to allow yourself adequate amounts of sleep, at least 7 hours of sleep per night, but still you're feeling sleepy during the daytime. And if you fall asleep in these situations and it's greater than 10, then you probably would want to have that checked out. Because there's 2 main things that influence the amount of daytime sleepiness. One is the sleep quantity, the other is the sleep quality. Sleep quantity, I mentioned you have some control over, but sleep quality may be influenced by things like medical and sleep disorders. So that's a very quick summary of sort of like sleep and the need for sleep. Now I'm going to shift on to a disorder of excessive daytime sleepiness, and it's called obstructive sleep apnea. It's actually been around or noticed for a long period of time, and even to the time of Charles Dickens, when in the Pickwick Papers, he wrote, and on the box, Sat a Fat and Red-Faced Boy in the State of Somnolence. And he actually referred to the character as Fat Boy Joe. Now, the reason why I show that is that about 30 to 67% of the people that have sleep apnea are overweight, as defined by body mass index of 25 kilograms per meter squared. But the rest are not. And for reasons that I'll detail later, that can be some of the reasons for causing obstructive sleep apnea. But obesity is definitely one of those factors. So what are the symptoms? Well, you have loud, disruptive snoring. Your bed partner notices that you have pauses in your breathing. And you yourself might wake up with gasping, gagging, choking, snorting sounds during your sleep. And that can be a tip-off that you might have it as well. And also, you have excessive daytime sleepiness. Now, I want to sort of contrast that with things like fatigue, tiredness, and exhaustion. So excessive daytime sleepiness means that, going back to the Epworth Sleepiness Scale, is that it's 10 or greater, that you definitely fall asleep during the daytime. Now, I contrast that with people that have things like insomnia, which I'll be talking about, where you feel run down, you feel fatigued, you feel tired, but you try to go to take a nap during the daytime. And the same mechanisms that prevent you from falling asleep at night also prevent you from falling asleep during the daytime. So you're not able to fall asleep during the daytime as well. And you contrast that with people that have obstructive sleep apnea. So people that have obstructive sleep apnea would fall asleep at the drop of a hat, so to speak. They would. We see many of the people that have obstructive sleep apnea in our clinic, and if we go to the waiting room, they're often, with their head back, falling asleep. So they can fall asleep at any situation. So that distinction is very important. People that have obstructive sleep apnea definitely are sleepy during the day, and given an opportunity to fall asleep, and if they're put in a bedroom with a dim light during the daytime, they'll definitely fall asleep. So this is a child that has sleep apnea. And if you listen very carefully, you can hear the pauses in breathing, and then you can hear the capture breaths afterwards, after the apneas. And you can see that the child really is struggling to take a breath because the airway is clamping down, and he's trying to bring the breath past that closed airway. And you just heard one just a second ago, that sort of pause in breathing. And it's no surprise that in the daytime, these children, when they wake up, they're often drenched in sweat because they have a real major workout during the night. And also during the daytime, it's not unusual for them to complain of headaches in the morning. Now, one thing that's sort of interesting is that children really manifest sleep apnea differently from adults. Does anyone here have any thoughts as to how the children manifest it differently from adults? I mentioned for adults, they're definitely sleepy, so they'll fall asleep during the daytime. But how do children who have sleep apnea, how might they behave during the daytime? Any thoughts from anyone? Short fuse, so they're definitely irritable, they're moody. Any other thoughts? Okay. Yeah, so difficulties with attention, focus, and concentrating. So these children very much mimic children that have attention deficit hyperactivity disorder. Because their sleep is being fragmented so much, they have this tendency to be hyperactive, have difficulty focusing and concentrating during the daytime, and they can be very moody or irritable. And I'll come back to that a little bit later. So if we look at the prevalence of people that have sleep apnea, it's about a quarter of adult men, 9% of adult women have sleep study evidence of having obstructive sleep apnea between the ages of 30 and 60. And about 40% of all patients in a primary care setting have evidence of having sleep apnea. And the risk factors or predisposing factors for sleep apnea are middle age, but children can still have it, as you saw. And for children, it's about 3% of the population. I mentioned obesity is a risk factor. Male gender, interestingly, is also a risk factor. So men tend to have it more often than women, except when women reach menopause. Then the numbers tend to equalize. So women tend to get it just as equal as men. If they make a decision to go on hormone replacement therapy, then these numbers come similar to that after menopause. Hypothyroidism is also a risk factor, and certain medications such as benzodiazepines. Benzodiazepines are mild tranquilizers, and they can be things like Valium or Ativan. What happens is, just like alcohol, these medications relax the upper airway. And when it relaxes the upper airway, it makes it more predisposed to collapsing. And when it is more predisposed to collapsing, you'll get these apnea periods that will fragment the sleep. And then there's anatomic abnormalities, which I'll also cover a little later. So besides the Epworth for identifying the sleepiness, you can also see if you have any of these other symptoms. So this is what's called a STOP questionnaire. It was developed by one of my colleagues, Francis Chung, in Toronto. And if you have 2 or more of these symptoms, you're at high risk. So if you have the snoring, you have the sleepiness, you have the observed apnea, and high blood pressure of unknown cause, then you're more likely to have sleep apnea. Now, going back to the anatomic abnormalities, so I mentioned that if you're overweight, what tends to happen is that causes the airway to be scrunched. And when it becomes scrunched, it becomes more susceptible to collapse. Also, if you have a small airway to begin with, that can also lead to obstructive sleep apnea, and I'll go into that as well. But one thing I wanted to really emphasize is that one of the things that we're really aggressive about in our clinic is to catch nasal obstruction, especially in children. So we'll look at the turbinates, and just to orient things, this is the nasal septum, and this is looking into the nostril, and you'll see this tissue that's not too far into the nostril called the inferior turbinate. And if you have allergies or especially allergies, what will happen is that this turbinate tends to get very enlarged, and that will cut off some of your breathing through your nose. Now, the reason why that's important, especially in children, is if you don't catch that early, a lot of times the children will turn into an obligate mouth breather, meaning that during the night, as well as during the daytime, they'll tend to breathe through their mouth. And that can have profound changes into the facial skeleton. So what happens is that the child tends to have a lower jaw or mandible that's pushed back. So this angle, and this is what's called a cephalometric X-ray, so it's an X-ray of the child's bony features. And what happens is when this mandible or lower jaw is pushed back, this angle tilts in this direction. In addition, there's a greater inclination at the mandibular occlusal planes. What that means is that this angle of the lower jaw and where the teeth meet, this angle can increase. So this angle increases, meaning that the child will tend to have a longer mandible, or wider mandible, meaning that this lower jaw dimension will increase. Lastly, they tend to have a greater inclination at the upper incisors, meaning that their front teeth will tend to be splayed out more. Now, the consequence of that is that you end up with a facial profile like this, where you tend to have a really long face, and you tend to, at rest, a lot of times your lips don't completely close. And that's because of the changes in the facial skeleton that cause remodeling of the skeleton based primarily on becoming an obligate mouth breather when the nose is occluded. So that's one thing that can result. But the other thing is also obesity. And I mentioned that when the person's overweight, especially in men, it tends to translate into the neck thickness. So people that have a neck thickness, or men that have a neck thickness greater than 17 inches in circumference, they're at a higher risk of developing sleep apnea. And the reason is this. So this black area is the airway, and you can see it over here. What happens is that there's these 2 lateral parapharyngeal fat pads. So there's 2 fat pads that lie on either side of the airway, and they increase in size depending on your body weight. So as the body weight increases, these lateral parapharyngeal fat pads increase in size, and they put pressure on the airway. and cause it to be more predisposed to collapse. And you can see the difference between this is a person without apnea and this is a person with apnea. And if you look at a 3D reconstruction of the airway, what you see is RP stands for retropalatal, or behind the soft palate, or behind the uvula. Retroglossal just means behind the base of the tongue. And what you can see is a person that has apnea has a narrow airway, extending from the soft palate all the way down to the base of the tongue. So how can you tell if you might have sleep apnea or physical markers that might predispose you to sleep apnea? Well, one easy way is just to go in front of the mirror, stick out your tongue, and say, ah. And this is, fairly routine in physician offices. And what we look for is we, first of all, look at the uvula. And we see if it's red and enlarged. Also, we look at the free edge of the soft palate. Is this area also red and enlarged? Now, if this entire structure is red and enlarged, you might just be recovering from a case of the flu. But if you see it all the time, what that could mean is that you're a heavy snorer and that you might have sleep apnea, because this area is very susceptible to vibration. So when you get a lot of redundant soft tissue here, what happens is it creates a vicious cycle, and that area tends to vibrate a lot and becomes very red and swollen. And that is responsible for some of the snoring as well as some of the apnea. Now, another thing that you can do is you can look at your edge of the tongue. One of the things that we look for is called scalloping. And what that means is that one of the things that might also cause sleep apnea, I mentioned, is a lower jaw that's pushed backwards. And when it's pushed backwards, or if the tongue is too big during development, what happens is the tongue doesn't quite fit in that lower jaw space. And because of that, the tongue is constantly hitting the back of the teeth. And so you'll get the scalloping. And the reason why that's bad is because that tongue can't fit well into that smaller space, it gets displaced backwards. And that in turn can make it more predisposing to collapsing the airway. So scalloping on the edge of the tongue is something we definitely look at. Now, if you open up your mouth, stick out your tongue and say, ah, and you don't see any of these structures, then please give me a call. Because that probably means that you probably have a pretty bad case of apnea. Because what that means is during development, these structures, the soft palate is actually diving down behind the base of the tongue. And that means that the airway itself is very compromised. And you can get an idea if you look over here. This is the uvula, and you can see the uvula is so elongated that it's actually doubled over. And this whole tongue area, it's called the genioglossus, you can see it's actually encroaching on the airway. So this black area is the airway. You can see that the tongue is actually, the base of the tongue is actually being pushed into the airway. So you can see with these different areas of obstruction, this can result in sleep apnea. And what are the consequences? Well, with sleep apnea, you can have problems with daytime functioning, you can have the daytime sleepiness, you're more predisposed to motor vehicle crashes, you can have depression, anxiety, irritability, all these types of problems. You can also have decreased cognitive function. So your ability to process learning and memory, attention and vigilance, and even the higher executive function, like, for instance, driving a car, will be impaired. You also have reduced quality of life. And a big thing is this cardiovascular and cerebrovascular disease. So you have increased risk of high blood pressure, increase of coronary artery disease, increase of heart attack, congestive heart failure, and stroke. And there's also evidence that you can have increase of chance of diabetes. If you look at mortality, this is a very large cohort of patients. It's called the Wisconsin cohort study. And they looked at patients over the course of 10 years. And what they found out was that they looked at the severity of sleep apnea. So if you have less than 5 abnormal breathing events per hour of sleep, you're not considered to have a diagnosis of obstructive sleep apnea. If you have 5 to 15 abnormal breathing events per hour of sleep, you're considered to have a mild case. 15 to 29.9 is moderate. Anything greater than 30 is severe. And you can see this linear trend over a 10-year period that people that tended to have more severe cases of sleep apnea, they tended to have a lower survival probability over the course of those 10 years. So how do we diagnose sleep apnea? Well, the minimum things that we need are a measure of the airflow through the nose and the mouth. We also need to look at the chest wall or abdominal wall movement. And then we need to look at the oxygen saturation in the blood. And it's often measured by a pulse oximeter that's placed on the finger. This is what we actually see in our lab. So the first two channels are brainwave activity, or EEG. This channel measures the chin muscle activity. This measures the right and left eye movements. This measures the left and right anterior tibialis, so we measure leg movement. We also look at EKG, we measure the snoring, and we look at the oxygen saturation in the blood by using that pulse oximeter I was mentioning. We look at nasal airflow, oral airflow, chest, abdominal wall movement, and then in some patients we put a small catheter, it's called an esophageal pressure monitor, into the nose, and it goes into the esophagus or food tube. And that picks up transmitted chest wall pressure. So we can see what the work of breathing is like. So what happens is from here to here, it's 2 minutes. And you can see that all of a sudden this person started having a decrease in airflow through the nose and the mouth. And then the chest and abdomen started trying to frantically pull in a breath. And finally, there was a tiny awakening. Now, these awakenings can occur 60, 100 times per hour in a person that has sleep apnea, but the person typically only remembers maybe 1 or 2 if they're lucky. Because these awakenings are so brief, they're just enough to get the breathing restarted. And so you can see the person woke up briefly, and then the breathing cycle returned, but then had another pause in breathing. And you can see the oxygen saturation starts dropping with each one of these abnormal breathing events. And normal oxygenation is about 90% or higher. Sometimes we see patients that are down to like 30%, which almost seems incompatible with life, but we do see these type of things occurring, and it makes you wonder if this could be responsible for some of the strokes and for some of the heart attacks that occur in the middle of the night. And there have been studies that have been trying to link that. So what are the treatments? Well, there's positive airway pressure. There's different types of this, and I'll go into this in a second. There's also different types of surgeries where they can cut some of the soft tissue. They can also cut some of the bony tissue to displace it forward. There's oral appliances, which I'll show a little bit later, as well as hypoglossal stimulation. I'll also show that later. There's also these nasal valves and stents. You might have heard of this thing called Provent, where it's a tiny adhesive valve that you put on both nostrils. And basically you can breathe in, but you can't breathe out because when you try to breathe out through the nose, it blocks it. So it puts pressure back into the airway and props it open. There's also nasal stents, which I'll talk about later. Negative pressure devices, there's this device called Winx, and it's basically an oral appliance that you stick in your mouth before you sleep, and it sucks your tongue forward by negative pressure and then moves your tongue a little bit forward. So it's opposite from CPAP, which provides positive pressure into the airway to prop it open. There's also weight loss, which is pretty ineffective in the sense that it can't, in most cases, cure apnea, but it does improve apnea. So if the person is overweight and loses weight, it can actually improve apnea, but rarely can it ever cure it. Behavior modification is just a fancy name for telling the person to either sleep on their sides or sleep at a 30-degree angle. And sometimes that can help in very rare cases. Medications are primarily respiratory stimulants, things like acetazolamide, but they haven't been really shown to be that effective. Now, these are the different devices. There's, and this is just the most common devices. There's continuous positive airway pressure, which is the most common. It's just a device that delivers pressure into the airway. Eye level pressure is mainly for people that have difficulty tolerating high CPAP pressure. And that delivers more pressure as you breathe in, less pressure as you breathe out. APAP is becoming more and more popular. In fact, that constitutes most of the devices that are prescribed. And basically what that is you set a pressure range, and then the device automatically adjusts by your breathing to give you more pressure when you need it, less pressure when you don't. ASV stands for Adaptive Pressure Support Servo Ventilation. And this is for people that have a different type of apnea called central apneas. And that can be due to heart failure. It can also be due to issues with the brainstem that regulate breathing. And because of that, what happens is there's this device that actually provides some ventilation during sleep. Now, the problem with any of the positive pressure devices is that there's an issue with adherence or compliance to the device. This is one of the largest studies that I conducted with 5 different centers across the United States, and we looked at over 1,000 patients, and we measured their adherence objectively by using their devices. And what we found out, as you can see, the most dense usage is between 300 and 500 minutes. But you can see there are a lot of people that use it less than that. So that's one of the big problems with any of these positive pressure devices, is that it is somewhat a cumbersome device, and it's hard for patients to get used to it. But once they get used to it, they can actually see dramatic effects in all those outcome measures that I showed earlier. These are some of the side effects. You can have nasal congestion, sore throat, irritation of the eyes and skin of the face. You can have mask leakage to the side of the mask. You can have abdominal bloating, nightmares and excessive dreaming, headaches, and rare meningitis. That only occurs if you have a base of the skull fracture. And what happens is the air might go into the brain, but it's very rare. This slide shows the effects, positive effects of CPAP. So this was a study that looked at patients that were given therapeutic CPAP and patients that were given a sham device or a placebo device. And the placebo device looks like a CPAP device. It gives a little bit of air, and it also sounds like a CPAP device, but it doesn't deliver therapeutic pressure. So this was a baseline period, and what you can see is when the individuals are awake, their blood pressure is higher compared to when they're asleep. But when they're placed on a CPAP device and they have high blood pressure, you can see a separation of their blood pressure. So their blood pressure decreases during the night. But interestingly, you can also see that when you wear CPAP just during the night, it also has a positive effect on your high blood pressure during the daytime as well. That's why it is considered an independent risk factor for the development and also continuation of high blood pressure. This is an oral appliance. It's basically a retainer or a mouth guard that you wear in your mouth. It clips on your upper and lower teeth, and this is just an example of one of them. And so what happens is when you wear it during the night, these tabs on the upper and lower pieces prevent your lower jaw from being pushed backwards. So you can open up your mouth, you can move it from side to side, you just can't push your lower jaw backwards. So it actually protrudes your lower jaw, and because of that, it opens up the airway compared to when you're at the natural position. So you can see the airway is a little enlarged. And this shows some of the advantages of oral appliances in that it's more convenient, there's more patient and bed partner acceptance, there's more tolerance, more adherence. The only downside is that it's less effective in treating the apnea. That's why we tend to prescribe it only for people that have mild to moderate cases of apnea. And across the board, it's about 60% effective. Now, if you look at upper airway surgery, this is what's called bimaxillary advancement. So they make cuts in the upper and lower jaws and displace it forward. And you can see what an effect it can make to the upper airway. It can dramatically increase the size of the upper airway. This is hypoglossal stimulation. Basically, what it is you have a stimulating electrode in the tongue and a neurostimulator that detects the breathing cycle. So when you have decreases in your breathing, it will give a small shock to your tongue to move it forward and to open up the airway. This is a fairly new device, but we've been using it on over a dozen patients so far with good results. We've also tested this other device. It's a nasal stent. It's a lubricated open stent that you place into your nose. And basically what it does is it props open the soft palate. It doesn't extend to the base of the tongue. That's why it might not be completely effective. And we're just evaluating it now, and we should have the results probably early next year. So now I'm going to shift to insomnia. As you can see, there's various causes of insomnia, anything from medications to psychiatric conditions to medical conditions. And there's even some sleep disorders that can result secondarily to insomnia, such as restless leg syndrome, which is an urge to move your legs. That's worse when you're at rest, worse at bedtime. There's also periodic limb movement syndrome during sleep where your leg movements kick and can also fragment your sleep. And sleep apnea, in some cases, can actually result in insomnia. But the basic symptoms are an inability to fall or stay asleep when desired, and you have a conditioned arousal to the bedroom environment or sleep-related activities. What that means is you start to get kind of tired when bedtime approaches, and then you start feeling really tired right after dinner, and then the moment your head hits a pillow, suddenly you're wide awake. So that's a conditioned arousal to the bedroom environment. And you also have increased somatized tension at bedtime. What that means is you might feel physically, emotionally, or mentally tense more and more as night approaches. These are two common types of insomnia. One is called psychophysiological insomnia, and it's kind of an interesting name because it might be both psychological as well as physiological. And an example of this is, for instance, someone that was a pretty good sleeper, and then all of a sudden had some type of traumatic emotional event. So say they underwent a divorce or they lost their job, and their sleep was really poor for about 2 or 3 weeks. But then what happened was then they had, say, a better relationship or a better job. So the initial trigger that triggered off the insomnia improved, but they still had the insomnia. So what we think happens is that the psychological behavioral event triggered off this insomnia, but then it somehow altered the brain chemistry or the neurons in the brain and resulted in a more persistent insomnia. Now, idiopathic insomnia is, we'll see a person that will come in and say, well, I haven't slept since 1960. And you realize, well, this is kind of a lifelong case of insomnia. And generally, it has something to do with control of the sleep-wake system. So what can you do? Well, behavioral techniques are used first, and I'll go into that. Relaxation, stress management, stimulus control, which I'll go into, can also be effective. An occasional mild hypnotic may be used, and I'll cover some of these hypnotics in a few minutes. Psychological or psychiatric counseling may be useful, particularly in people that have depression or anxiety disorders in addition to insomnia. So relaxation therapy is one thing that can be tried, and it can improve the sleep efficiency, meaning that it can improve the time spent asleep over the time in bed. And you can see it can improve the sleep efficiency up to about 72%, meaning that it enables the person to sleep more of the time that they're in bed. And one of the techniques is progressive muscle relaxation. Now, you might have heard these tapes before. What they tell you to do, these tapes will go in a very soothing voice and tell you to tense up your thumb, relax your thumb, and they'll tell you to do that for a few seconds. And also then do it for your hand, do it for your elbow, do it for your shoulders, and so on. And so by doing that, you can decrease your wake time by 20 to 30 minutes. Meditation, self-hypnosis, biofeedback can also improve your sleep efficiency. Sleep restriction is a more advanced technique. What it can do is reduce your wake after sleep onset by over 50% and improve your sleep efficiency by about a quarter. And this tells you how to do it, but basically what we tell patients is to standardize their wake time. So if they normally will get up at say 6 o'clock, we tell them to keep that anchor at 6 o'clock. Then what we tell them to do is if they normally go to bed at say 9 p.m., tell them next week to go to bed at 9:15, next week 9:30. And then keep on doing that until they reach a point where they're very sleepy during the daytime. And when that point approaches, then back off by 15 minutes. And by doing that, as I said, you can improve your sleep parameters. You can make your sleep more efficient because it's actually squeezing out the awakenings that you have during the night. Now, temporal and stimulus control techniques, I mentioned the stimulus control earlier. You can expect a 52% improvement after 1 year. So what these control techniques mean is you standardize the waking time, you avoid daytime naps, you turn off the light immediately upon retiring, you avoid reading, watching television, eating, or working in bed, and you try to follow this 20-minute rule, meaning that if you can't fall asleep in 20 minutes or can't fall back asleep in 20 minutes, you should get up, go to another room, do something that will make you drowsy, whether that's meditation, stretching, whatever that will make you drowsy. When you feel drowsy, then go back to bed. And you should estimate the 20 minutes. You shouldn't constantly look at your watch because that in and of itself is non-sleep promoting. Now, one thing that's very important is phototherapy. And what that means is that if you get bright light in the morning, you can advance your sleep onset, meaning that it will make your sleep onset a little earlier. Bright light in the evening can phase delay your sleep onset, meaning that if you get bright light in the evening, it can actually make it harder for you to fall asleep. So for in the morning, what we recommend is a light intensity at least 2,000 lux for 30 to 45 minutes. And we tell patients within 5 minutes of getting up, go outside because you'll get a lot of bright light. Now, if you get up before sunlight, what happens is you can get these bright light boxes off of the internet. And you just want to make sure that it can deliver, and most of them do deliver about 10,000 lux. And optimally, you should stay about 18 inches away from that device. And then if you get about 30 minutes of bright light exposure, that can affect that suprachiasmatic nucleus that I was telling you about that's in the brain that governs your sleep-wake cycle. So by doing this, it can actually help you to fall asleep. And on the flip side, you should avoid any bright light at night. So within 2 or 3 hours of bedtime, you should avoid any bright light. And that includes using the smartphones, laptops, because not only can that be mental in terms of just using a mental activity, what it also does is it produces blue wavelength of light. And that can also tend to resynchronize your circadian rhythms and make it harder for you to fall asleep. Now, if you do need medications, there are some prescription medications that actually work pretty well for the short term. One is zolpidem or Lunesta. And we might prescribe this for people that have difficulty staying asleep because it has a pretty long half-life. Now, Ambien and Sonata, you notice they're fairly similar in terms of they're fairly quick acting and their half-life is short, so they don't stay around a long time. So that's why we'll tend to use it for people that have sleep initiation difficulties. Now, zolpidem extended release is sort of between zolpidem and between Ambien and Lunesta in terms of the half-life. So it can help in sort of intermediate cases. But there's always adverse events, and these are just some of those that can happen. You can also have one thing that has become very much in the news is these parasomnias. You can have sleepwalking with some of these, and you can have confusion in the morning. So it's very important to be careful of this. So in the remaining minutes, what are some of the do's that you can do? Well, as I said, maintain regular bedtimes and awakenings. Try to optimize your sleep amounts. Make it at least 7 hours. Use the bright light in the morning. Create a comfortable, quiet, dark, and temperature-controlled bedroom environment. And establish a regular pattern of relaxing behaviors within an hour before bedtime. So go into a ritual that will help you to fall asleep. Try to get exercise on a regular basis, but avoid it within 2 or 3 hours before bedtime because it can be stimulating. Now, don't take a nap. There's always exceptions. And the exceptions are if you're about to get behind the wheel of a car and you're sleepy, or if you take a nap every day at the same time for the same amount of time, then your body's used to it and it's okay. But if you have to take a spontaneous nap, you should try to take it for about 20 minutes. If you take it longer than 20 minutes, what will tend to happen is you'll have this thing called sleep inertia, which means that you'll end up end up very groggy after taking an extended nap. And the reason is that you're going to go into the very deep sleep, the N3 sleep. What you want to do is you want to get into the N1, N2 sleep, which is a lighter sleep, and that will be restorative for you for the next couple of hours, but it will prevent you from getting the sleep inertia. You should avoid eating or drinking heavily before bedtime. You should set a limit of the 20 minutes I talked about. Just sort of in your mind, estimate what the 20 minutes is, and if you can't fall asleep or can't fall back asleep within 20 minutes, just get up and go to another room. Do something that makes you drowsy. Try to avoid disturbances. You should avoid reading or watching television in bed unless these activities definitely make you drowsy. And then you should avoid the use of alcohol, caffeine, or nicotine. So this is just a slide telling a little bit about our center, and I'd be happy to answer any questions that you might have at this point.
Yes, my name is Art. Can you recommend or point to any research where you just touched upon it just recent in the talk about, I might call it high-tech sleep hacking, where you might use some kind of a electrical stimulator to, because as we get older, we get less deep sleep, and if we could increase the deep sleep, that would probably be beneficial, but we don't want to take drugs to do that particularly. So do you know of any research that we could look to?
Okay, the only thing that tends to work consistently in improving insomnia is cognitive behavioral therapy. And those are the slides that I was showing you at the end to behaviorally improve your sleep.
It's beyond that.
Oh, beyond behavioral therapy?
Beyond the behavior therapy, like high-tech cerebral electrical stimulation at 1 hertz, say.
Right. So, there have been some studies that have looked at transcranial stimulation of the brain. And I just happened to look at some of the articles a few days ago. But that work did not show a convincing improvement.
Well, anything brand new can't have showed anything in the long term. Right. So that's not necessarily condemning, and it just says there's not enough data.
Yeah, there's probably not enough data at this point. But other than that, other than medications, other than cognitive behavioral therapy, there haven't been really, technological improvements for helping sleep. We actually, in my lab, we're actually partnering with a tech firm here in the Bay Area, and hopefully we're working on a model that might, I probably can't say much more. Well, in about maybe a couple months to a year, if this study works out, it might have some promise. But it's sort of along the lines of what I was talking about, a stimulating device.
Thank you.
Yes, is there, first of all, any correlation between heavy physical activity and sleep need? For instance, professional athletes, do they need more sleep? Or could physical activity be actually therapeutic? As we grow older, we do less physical activity, and perhaps that affects our ability to sleep. And the second, is there any correlation between heavy mental activity, intense mental activity, and sleep need? For instance, kids that play video games, age 14 to 19, and do nothing else, I understand sleep an average of 14 hours a day.
So in answer to your first question, there have been studies that have looked at the effect of exercise on sleep. And particularly if it's administered in the morning or early afternoon, it can have improvement in sleep parameters. So it can improve your sleep efficiency as well as your ability to fall asleep. And actually there was an article within the last month that looked at actually patients that were elderly, like above 80 years of age. And what they showed was even with a moderate exercise consisting of stretching, as well as some kinetic exercise, both of those types of exercise had an effect on sleep in a positive way. So exercise, absolutely can improve sleep. Now, your other question was about children.
Mental activity, video games, intense, and then they sleep 14 hours a day.
Yeah, so, we tend to recommend against that if a child or adult has difficulty sleeping. If they don't have difficulty sleeping, or if they don't, sleep a long period of time, then that's fine. But interestingly, there have been studies that have looked at the effect of video games on some sleep disorders. And for instance, restless leg syndrome that I was just talking about, that is a pretty common sleep disorder where you have an urge to move your legs that can disrupt your sleep. When they've had subjects play video games, it actually improves the restless leg syndrome. And that could be related to like distraction or other processes. But I thought that was kind of interesting that in some cases, using video games can actually improve sleep.
Thank you.
If you've been diagnosed with narcolepsy, other than taking Ritalin, are there any recommendations to keep yourself awake during meetings and sermons?
So with narcolepsy, Ritalin is one of the more common stimulants that are used. Now, if the person doesn't have cataplexy, and cataplexy is that sudden loss of muscle tone that's associated with sudden emotions such as laughter, anger, surprise. If they don't have cataplexy, then stimulants and scheduled naps are considered, first line. The other type of treatment that's fairly used is relatively new medication called Xyrem. It's XYREM, and the generic name is sodium oxybate. And what that does is it helps to consolidate sleep at night, so it reduces the fragmentation of sleep for people that have narcolepsy. It also helps a little with the cataplexy. So aside of Ritalin, there are other medications that could be tried if the person has cataplexy or doesn't have cataplexy. But it's something that should be discussed with their sleep specialist.
Thank you.
Yeah, I was curious as to why you didn't mention taking synthetic melatonin. And I've been taking it for 25 years. I estimate that it has increased my nightly sleep by an hour and a half, so 45 hours extra sleep a month. Some friends say to me, well, don't do that because your body's going to produce less melatonin if you're taking the artificial stuff. And I say to them, well, I take time-release melatonin. I fall asleep easily, even when I forget to take it. What it's doing is it's keeping me from waking up after, like 4 in the morning instead of waking up at 7.
So absolutely. The reason why I typically don't mention melatonin unless I'm asked a question about it is because it's not an FDA-approved medication. It's actually a substance. But that said, it can be helpful for people that have insomnia, also people that have shift work problems, and also non-sighted individuals. It can be very beneficial in helping with the circadian rhythms. And so, using melatonin can be effective. The thing about the administration is you have to be careful about when you take the melatonin, because it's actually optimal at the time when the temperature curve is lowest. So that slide that I showed, where there's a peak of melatonin, it actually coincides with the drop in body temperature. So when you take it close to that drop, it can help with your insomnia.
Time release should solve that problem.
It should solve that problem. So but you might have to play around with when to administer the dose. The other thing is that there is a FDA-approved medication. It's called Ramelteon. It goes by the name Roserum, but so far it hasn't been shown to be that effective with insomnia compared to either cognitive behavioral therapy or other medications. So,
and what about taking melatonin decrease my body's capacity to produce it?
Oh, that's interesting. So, will taking melatonin have an effect on your endogenous melatonin? I don't think that's been studied enough to actually tell whether or not that's true, but certainly, for if you have insomnia or shift work sleep disorder non-sighted, I think it does have a role at this point.
Has there been any study on CPAP for people with insomnia or people with dementia that it improves cognitive performance for those people that do not have obstructive sleep apnea, just standard?
Okay, so people that have insomnia And does it improve their mental cognition by using
Mental cognition
CPAP.
or improve their
Yeah.
REM sleep.
That's tricky. That's a very tricky question because, there's some people that believe that most insomnia cases, especially sleep maintenance insomnia, where you can't maintain your sleep, a lot of those cases are caused by sleep apnea. And what's interesting is, even from personal experience, I've been doing a study over at the VA, the Palo Alto VA, and we're looking at a lot of individuals that are in their 70s or 80s and who respond to an advertisement for symptoms of insomnia. And I'd have to say that a large percentage of those patients actually have undiagnosed sleep apnea, even though they present with insomnia. Now, with respect to your question about insomnia having an effect on neurocognitive effects, there are some papers that do indicate that lack of sleep, as well as in some patients that have insomnia that have been ruled out for other causes or other sleep disorders, there can be a decrease in cognitive function. But I think by far it's not definitive yet.
I'm curious about dreams. So I, on a near nightly basis, have incredibly vivid dreams. I'm not on anything, I'm sober, but they're very, very vivid. And I remember dreams back to when I was, 3, 4, 5, 6, 7 years old, 27, so it's not that long. But, and meanwhile, many of my partners barely remember their dreams at all, male partners. And I'm just curious why I maybe or have such vivid dreams when others do not, and why I remember them so strongly.
Yeah. So one thing that might be responsible for it, and I'm not sure, but one thing that might be responsible for it is that 90% or more of the dreams occur during REM sleep. So if when you wake up in the morning, your sleep pattern of when you wake up is variable. It could be that you're catching it in the middle of REM period, and that's why you remember it. The other thing is that most people don't have a 24-hour cycle. So their 24-hour period is actually extended like 24.6 hours. So that means that they have a natural tendency to want to go to sleep later and get up later. So so if you do get up every morning at the same time, and you're one of those people that have an extended clock, that can also cause you to remember your dreams, because your major REM period will tend to be delayed each successive night, and the REM periods tend to get longer, more intense as the night wears on. So actually, most of the REM sleep occurs just before a person wakes up. So that could explain, but otherwise, I'm not sure.
I vaguely remember Dr. Dement talking about lucid dreaming, but I don't think I was paying enough attention.
I'm wondering if it's detrimental over a long period of time to be required to get up every 2 hours to urinate in the night if your total hours are about 9 hours. Is it bad over a period of time, maybe 40 years?
Right. Well, the interesting thing is there's been studies that have looked at bladder capacity and sleep. And what they found out is that the bladder would have to be extremely distended in order to wake up the person from sleep. That's why whenever a patient comes in and has that as one of their primary complaints, we typically will...
Doesn't happen to me.
Sorry?
Very little.
Yeah. Well,
But every 2 hours.
Right. But we'll tend to do a sleep study. And what we find out is that a lot of times it isn't due to the urge to urinate. It isn't due to the bladder. More commonly, it's due to other factors. And one of the big ones is obstructive sleep apnea. There can also be periodic limb movements that are causing the person to wake up. But it can also be as simple as just something in the external environment, like noise or the bed partner. It can be many different causes, but that's one of the things that we really look at, because it's very unusual for a person to wake up just because of their bladder being distended. It would have to be very much distended to wake the person up.
My question is, over a long period of time, do you find that it's detrimental to your health?
In the very few cases where it's caused just by increasing bladder capacity of waking the person up. There hasn't.
But
been any
otherwise, you're
repercussions.
not worried about it.
Yeah, otherwise we don't really worry about it. But we do tend to strongly suspect other causes for waking up due to the ability to urinate. Sure.
So if you have a similar question, but if you have BPH, does that, and it wakes you up every couple hours,
Yeah.
is that something that is caused by the BPH or is it caused by apnea and you just then?
Yeah, so BPH is different in the sense that if the person has BPH, it would tend to maybe wake the person up during the middle of the night and then have to go to the bathroom because it would exert pressure and cause the person to wake up. So yeah, in those cases, and the same thing goes with, I forgot to mention, is if the person has a chronic pain syndrome, as the person gets older, they might have some pain that might tend to wake the person up as well.
Okay, thanks.
Oh, sorry.
I was talking to somebody today who said he never gets jet lag. He travels a lot. And he said, oh, no, I exercise. I don't drink on the plane. I have a terrible time with it the first night or two. And if I take something like Sonata, it's wonderful, but I have a problem with it 3 days later. When I quit, then I have a reaction.
So for jet lag, one of the things that can be done to help is what some people will do is they'll try to stay awake during the flight, and that will help, especially if it's a long flight, to help adjust to the new time zone. And then the other thing that can be a benefit is that to use bright light. So within 5 minutes of getting up at the expected awakening time at your new time zone, to make sure you get a lot of bright light exposure within 5 minutes of getting up, and then avoiding the bright light at night, because that's one of the strongest stimulants to help resynchronizing the internal clock. You can also try melatonin, as was mentioned. So melatonin and bright light are some of the ways to help compensate with jet lag. The other way is what you mentioned by taking medications. But
I really don't like the medication idea, but
yeah, it can definitely cause problems. But bright light, melatonin are other things you might consider.
thank you.
Two questions. One is that you had indicated if you can't go to sleep for like 20 minutes, go to another room. And the question is, what do you do, and what if you can? How long would you do whatever you do before you just kind of give up?
Right. So some people will meditate or do very light stretching. Some others would also read a very boring book. But if you read, you should definitely read it in a very dim light, and try to stay away from reading it on a tablet, because you'll get that blue wavelength of light. So these are some things that you can do. Now, if you're the type of person that the reading doesn't really help you to fall asleep, then you should avoid that. But just things like meditation, light stretching, listening to soft music, anything that will normally tend to help you to fall asleep, you should do. But you should do it in a very dim or dark environment.
How long would you?
Oh, just until you start getting drowsy. Until you start getting drowsy, and then
What if you don't after?
if you don't, right? So you would just keep on doing it, and then what would happen is when you reach your normal awakening time, say you've been kept awake for 2 or 3 hours, and your alarm goes off, then what you should try and do is to try and maintain your alertness the next day if you can, and if you can't, to take only a 20-minute nap. But if you can extend it to your next bedtime, that would be the best thing, because then you really try to get in the habit of falling asleep at your desired bedtime, waking up. So put a little bit of sleep pressure, sleep debt on you until your next cycle.
And the second question is, you indicated like no alcohol and no tobacco, but it seems like if you have a cup of coffee in the morning, 1 cup once in a while, it wouldn't matter that much. And the same thing with alcohol, occasional glass of wine. So could you kind of quantify at what point it would tend to be too much to make a insignificant difference?
Yeah, so caffeine isn't bad if you take it in the morning and your body is used to it, and it doesn't necessarily prevent you from falling asleep. So in that context, it's okay. The reason why we tend to tell people to avoid it is that they have really bad insomnia. because even small doses of caffeine can, cause a person to have difficulty sleeping. Alcohol, interestingly, can have a person fall asleep quicker. The downside is it cuts into REM sleep and non-REM sleep and reduces total sleep time. In addition, if the person is predisposed to apnea, as I mentioned, can worsen apnea. But if the person takes it early enough, before they fall asleep, and they, do it consistently, and it doesn't really have that much effect on sleep, then then it shouldn't be an issue. It's only if the person has insomnia that we tend to tell people to cut back on some of these things.
My mother was in the hospital for a long time, and I was sitting there for a long time, and it seemed like there were many interruptions and noises and a very difficult environment for rest. And I'd always been told that rest was conducive to healing. Has anybody looked at sleep-optimized delivery of hospital care, maybe looking to see if it could shorten hospital stays for people?
Yeah, that's a very good question. And there have been a few studies, but definitely not enough. And because it's hard to actually do these type of studies within the ICU environment. And that's where most of the studies have been done. They've been done in the intensive care unit. And the studies have shown a positive effect when they kind of limit the amount of interruptions and when they actually dim the lights in the area. So it can have a positive effect, but yeah, there's been very few studies that have looked at it.
Thank you.
Sure.
Okay. So I've had all kinds of sleep disorders, and I had all this, what Dr. Dement used to call stage 4, the sleepwalking, sleep talking, bedwetting, I had all that when I was younger. So the first question is, do you think that those kinds of sleep disorders can make you more likely to have something like apnea, or are they just totally unrelated? And the second question is, so I do have apnea, and I've got all the, I've got the overweight, diabetes, high blood pressure, all that stuff. Lord knows how long I had it before I was diagnosed. I now have been on my bilevel PAP for about 3 years, and I'm pretty good about using it regularly. So can I reverse any of the bad stuff that happened to me, or am I just screwed?
Yeah, no, it's kind of interesting because, the sleepwalking episodes that you mentioned, what happens is, our current thinking is that those episodes are actually triggered by either external or internal events and in predisposed individuals. So if a person is predisposed to have sleepwalking and is subject to really loud noise within the bedroom, or has an apnea event, during sleep, those type of things can actually trigger off a sleepwalking episode. So one of the things, especially in children, what we'll tend to do is we'll tend to screen them for apnea and also other things that might be fragmented in their sleep, because it turns out that it sounds counterintuitive, but these type of events, whether it's loud noise or bright light or an apnea episode, can actually trigger off the episode. So it is kind of interesting. And what we find out is that when we treat something like apnea in a child, when their main complaint was sleepwalking, it can actually reduce the amount of sleepwalking episodes.
Interesting. But the second question is, so let's assume I had apnea for anywhere from 5 to 40 years. Who knows how long I had it before it was diagnosed. And now I've been on the CPAP, or bilevel PAP for 3 years. I mean, I understand that hopefully I'm not going to get any worse because I'm treating the apnea, but you don't actually gain back anything, right?
Well, it puts a pause in the health consequences of sleep apnea. So by treating the apnea, it actually tends to improve things like the cardiovascular consequences, like the risk for stroke, heart attack, high blood pressure. It does tend to improve that. So that's why, it's important to get treated for that.
Thank you.
Okay, sure.